A very good afternoon to the esteemed audience collected here. I thank the organizers, especially Vitull Gupta sir, for providing me this opportunity to speak on this stage. Now my topic is an often ignored one in our routine clinical practice. Charcot foot is an inflammatory disorder which is progressive over time. It was first described in 1868 by Jean-Martin Charcot, who was a French pathologist and neurologist. He described this disease in patients of tabes dorsalis. So coming to the epidemiology, we have eye-opening numbers about epidemiology of Charcot foot. It is prevalent at around 0.1 to 7.5% in patients of diabetes. But surprisingly, the prevalence rate goes up 5 times to 35% in patients of diabetic neuropathy. We have bilateral involvement of the feet between 9 and 75%, which is a very huge number. This disease mostly presents in the 6th and 7th decade of life, and most of the patients are having a long-standing history of diabetes for a minimum of 10 years. We have an estimated 63% of the patients with Charcot neuropathic osteoarthropathy who in future are going to develop a foot ulceration, and we all know the complications and the difficulties of managing a foot ulcer in itself. So what are the risk factors for developing Charcot? Well, the numero uno factor still remains diabetic neuropathy. Along with that, we can have poor blood circulation, previous trauma or injury to the foot. We can have foot deformities or foot ulcers. Another important factor is increased BMI, which is associated with increased incidence of Charcot arthropathy. And worryingly, the BMI is increasing not just in the 30s and 40s. Now we have students of school-going age who are overweight or obese. So some diseases which are linked with Charcots are Parkinson's, HIV, sarcoidosis, rheumatoid arthritis, and psoriasis. So we have two distinct pathophysiologic mechanisms for the development of Charcot foot. One is the neurotraumatic, the other one is the neurovascular. In the neurotraumatic theory, we have repeated trauma which leads to joint destruction. In the neurovascular theory, we have increased blood flow, and this leads to sympathetic failure and AV shunting, causing osteolysis, osteopenia, and bone atrophy. Well, Charcots mostly develops in the foot, but it can also develop in the shoulder and elbows. And we have this pictorial representation of the pathophysiology, both the neurovascular and the neurotraumatic theory. So we can see that the inflammatory response which is triggered, it disrupts the bony architecture of the foot, and this creates abnormal plantar pressures. And when we have abnormal plantar pressures in the foot, such a foot is at an increased risk of ulceration, osteomyelitis, that is infection, along with amputation. So what are the stages of Charcot foot? We have two different classifications. One is the Eichenholz classification, which is based on the clinical and the radiographic findings. The other, Sanders and Freiberg classification, is based on the anatomical locations. So coming to stage 0 or pre-Charcot prodromal stage of Eichenholz classification, clinically the patient will have red hot and swollen foot without any deformity, and we will have a completely normal radiograph. In the stage 1, that is the development or destruction stage, the patient will have an erythematous foot with elevated temperatures but without any pain. On the radiograph, we will have bony debris at joints, fragmentation of the subchondral bone, joint subluxation with or without fractures. In the stage 2, that is the coalescence stage, we have decreased signs of inflammation. The inflammation starts to subside. But on the radiograph, there is worsening of the stage 1 features. Now, there is absorption of the bony debris along with new bone formation. We have coalescence of large fragments with sclerosis of bone ends. Now, in the last stage, we have complete resolution of the inflammation with changes in the overall foot architecture. On the radiograph, there is remodeling of the affected bones and joints. Now coming to the Sanders and Freiberg classification, This is based on the anatomical location and the various percentage is given. Here we see a classic Charcot foot in the acute active stage where the foot is swollen, red and hot. Now you can see a healthy foot over here compared to a Charcot foot where you have fused joints, the twisted first metatarsal bone, bony fragmentation, and the last stage of the Charcot foot in the Eichenhorst classification, that is the rocker bottom deformity. This is the radiograph of the rocker bottom deformity. Now coming to the symptoms of Charcot foot, see, our patients of diabetic neuropathy, they are oblivious of pain sensations and they repeatedly suffer trauma of which they don't take note of. Now this might be noticed in the form of swollen red or warm foot, or the patient might have difficulty fitting into a shoe. So that is when they present to a doctor. These patients can have loss of sensation and obviously over time they will have foot deformity. Now why is Charcot so important? It not only hinders the quality of life of the patient, but it also carries its own set of complications. The patient can suffer from foot deformities like flat foot, rocker bottom foot, hammer toes, ankle equinus contracture. The bony prominences, they can lead to ulceration, infection, and not just loss of limb, but also loss of life if not treated properly and in time. We also have recurrence of Charcot joint. Now, can we ever imagine that a disease like Charcot foot would be carrying 13% mortality over a period of 5 years? And this is similar to patients of diabetes who are not having Charcot. This calls for increased awareness about Charcot foot and its diagnosis and management. So how do you diagnose Charcot? Well, the first basic principle is to have a high index of suspicion, because when patients present to us with a red hot and swollen foot, we end up misdiagnosing Charcots as, say, osteomyelitis or gouty arthritis or DVT and other infections. So a clinical exam and a proper history taking is of paramount importance. X-ray is the first investigative modality which we should order in such patients. MRI and bone scans can be reserved for patients where X-ray is negative. Bone scans also help in early detection, like DEXA. So here we have a lateral X-ray of a Charcot foot deformity, which shows dislocation of the tarsometatarsal joint with break in the talo-first metatarsal line, which is shown by the dashed lines, and a reduced calcaneal inclination angle showed by the solid lines. So on radiographic evaluation in a patient of chronic Charcot neuropathy, you see osteophytes, joint consolidation, and arthrosis. Deformity begins with the medial column and it proceeds to the lateral column in the later stages. So how do you manage Charcot foot? The basic goal is to achieve a plantar grade foot which is stable and is able to fit into a shoe. We need to prevent recurrent ulcerations in patients of Charcot neuropathy. So in this stage 0, you don't need to do anything. You just need to monitor the patient. You need to counsel them about the need for monitoring and frequent follow-ups. You need to do serial radiographs to look out for the development of stage 1 Charcot neuropathy. Now here, the importance of foot care in diabetic patients cannot be underemphasized. We need to counsel our patients about foot care, not walking barefoot, wearing the proper fitting shoes and avoiding the tight fitting ones, about the use of moisturizers and emollients so that they do not have a dry skin which is more prone to injury. In stage 1, we have to immobilize the patient. Foot and not weight bearing has to be done in a total contact cast. In stage 2, we do protected weight bearing with a total contact cast or a molded total contact polypropylene ankle foot orthosis. Now in the last stage, if the patient has a plantar-grade foot, then surgery can be avoided and we may use custom inlay shoes. But if there is a non-plantar-grade foot or recurrent history of ulcerations, then we have to go for debridement, exostectomy, correction, or fusion with internal fixation. If there is osteomyelitis, debridement has to be carried out with or without staged reconstruction with internal or external fixation or amputation in some cases. Now, in the acute phase, how do we achieve immobilization? We can do it with total contact casts or removable Walker braces. There are some advantages and disadvantages of both these modalities. The removable Walker braces, though they are of low cost and more affordable, but they cannot fit into all the deformities and they have limited compliance. However, total contact casts, despite their high cost, they can fit into the severe deformities and have a better compliance. The thing to watch out for in a total contact cast is that we should not prolong the total contact cast duration unnecessarily, because we have to monitor the patient. If the edema has subsided and there is radiological improvement, we should remove this cast. Otherwise, we will have joint stiffness and disuse atrophy. Are there pharmacological options? Well, there are pharmacological options, but till date, they have not been proven to be of much great benefit. Bisphosphonates can be used, and they help the acute phase of Charcot as they inhibit osteoclastic reabsorption. Calcitonin is an excellent alternative in patients with renal dysfunction. We also have pamidronate and zoledronic acid, which can act on the new hydroxyapatite crystals by blocking osteoclast precursors in the newly formed bone matrix. Now, medical optimization is very important. We have to advise the patients of diabetes and also of Charcot foot to stop smoking cessation. HbA1c targets, as advocated by the American Diabetes Association, has to be individualized. A person in their young 30s, they can have an individualized target of, say, an HbA1c of 6% if they are not suffering hypoglycemia. However, an elderly person in their 70s or 80s can have a relaxed target of 8% if they have already had complications. We need to recognize micro or macrovascular disease, which can lessen the complications post-operatively. Now, when do we go for surgical options? So the main rationale behind Charcot reconstruction is surgical offloading to prevent ulceration and deformity progression. So the modalities available are exostectomy and Achilles tendon leathening, plantar osteotomy, osseous debridement, realignment osteotomy, selective or extended arthrodesis, and open reduction with various forms of internal fixation with or without external fixation. Amputation, which is the most dreaded complication which can handicap a patient, well, it is done only after failure of previous surgery. It is performed because there is an unstable arthrodesis or recurrent ulceration or infection. So here we have an example of a Boyd's amputation in a person with Charcot foot. So this algorithm sums up how we should manage Charcot foot. First, we have to do an X-ray, and if it is positive, we go for offloading and redistribute the weight bearing through total contact cast or removable Walker braces. But if this is ineffective, we have to go towards the surgical management. Proper footwear has to be advised to the patient after the total contact cast has been removed. MRI or nuclear imaging should be carried out if the X-ray is negative, and osteomyelitis must be treated. However, if the MRI or nuclear imaging are negative, we have less chances of it being a Charcot foot. Now, coming to the multidisciplinary team approach, it is very important to have a good team to manage patients of Charcot foot. It is not just the physicians or the diabetologists or the orthopedicians domain. Such patients benefit greatly when you have an MDT team in the hospital or your clinic or the medical colleges. And this concept still remains alien in most parts of India, where people are not ready to collaborate with other branches and consider multidisciplinary consultations. We can say that this might increase the cost of treatment, but ultimately this will also increase the quality of the care we provide to the patients of Charcot foot. So I would come to my conclusion. The awareness on Charcot foot still remains low. We need to aware our physicians, our interns, our postgraduates to look out for Charcot foot in their routine clinical practice and have a high index of suspicion. Diabetes remains the #1 cause. The initial treatment has to be offloading. Surgical treatment is reserved for chronic recurrent ulcerations, unbraceable deformity, acute fractures, or dislocation or infection. Thank you.